Hello, everyone. This is Dr. Bishal Gyawali from Queen's University, Kingston, Canada again. Thank you for joining us on our next lecture on how to read clinical trials. And we're dealing with methods. And currently, we're dealing with surrogate endpoints. This is going to be a big topic, so we'll have a number of lectures on this. But I would highly encourage you to watch these videos in the order that they have been published in our website so that it makes sense to you when you are joining this video. So we are continuing about our discussion on surrogate endpoints. In the last video, we discussed what is a surrogate endpoint and how we validate a surrogate endpoint. So in today's lecture, we'll ask a different question. That is, why do we even need surrogate endpoints? Why not just measure overall survival and quality of life? And why bother with all these surrogate endpoints? Because as we discussed, OS and QAL are the primary outcomes of clinical benefit. So why measure something else? And the answer to that is measuring overall survival takes a long time. And people argue legitimately that patients do not want to wait forever for the survival endpoint to reach because it would be too late. Therefore, we need an endpoint that we can measure relatively quickly and get the drug approved relatively quickly, which is a good argument, and that makes sense. But let's see what the data shows about how much time we save by using a surrogate endpoint instead of using overall survival. So how efficient is using surrogate endpoints in clinical trials? There have been a couple of studies looking into this, which I have cited in this slide. In one of the studies, they found that compared to using overall survival, if you used progression-free survival, then the trial duration would shorten by an average of 11 months. And if you used response rate instead of OS, you shorten the trial duration by 19 months. Now, this is some time saving, but it's not like forever that people think it is. As you can see, it's a little less than 1 year for PFS, a little more than 1.5 years for response rate, that the trial duration is shortened. But it's not like 4, 5, 6, 10 years that people think it will take for overall survival results to be announced. So there is some time saving, but not by a much. On the flip side, if we don't measure OS, we would never know whether survival would improve or not. So there is a trade-off there. And the problem is, sometimes, even after multiple trials, the surrogacy may not be fully established. For example, we did this study of the validity of surrogacy of progression-free survival in breast cancer women who are treated with bevacizumab. And we found that there were 7 clinical trials, which is rare nowadays for the same drug to have 7 clinical trials in the same cancer setting. But in this case, there were 7 clinical trials. And even after 7 clinical trials, if someone asked, is PFS a good surrogate for OS? The answer was maybe. We don't know. That is, even after 7 clinical trials, we could not fully validate or unvalidate the surrogacy of PFS with OS in this setting. So instead of needing to guess forever, we can save time and we will have clarity of information if we just measure OS. So what about the surrogate endpoints that we have that have been tested and tried to be validated so far? And the evidence shows that, as you can see in this graph, especially in metastatic setting, most of the surrogate endpoints have very low trial level correlation. And there are some settings where there is strong validation, but you can see that in majority of the cases, the validation of the correlation is pretty weak. So despite the name surrogate, they are actually not a good surrogate. Just to give you an example, if we look at breast cancer alone, this is what we found. For pathological complete response, it was not correlated with overall survival. Disease-free survival, overall, it was not correlated, but for HER2 positive subgroup alone, it was strongly correlated. Response rate, it was not correlated with OS. Progression-free survival, there was only mild to moderate correlation, which was not sufficient. Event-free survival, there was a moderate correlation. So we need to think about surrogate endpoints validation not as a one-size-fits-all thing, that is PFS a good surrogate for OS? That's not a good question. We need to be very specific. Is PFS a good correlate for OS in first-line treatment of breast cancer treated with HER2 positive agents? Because the correlation will differ based on the tumor type, based on the settings, based on the drug that we are using. So it has to be very specific. The other question people ask, which is again a good question, is that, okay, PFS is not a good surrogate for OS, but is it a good surrogate for quality of life? Does improving PFS correlate with improving quality of life? And we tried to answer that question in this paper that I cite here. And we found that half of our trials, they do not even bother including quality of life as an endpoint. Of those that did include quality of life as an endpoint, a quarter did not report on them. So that is a huge, waste of resources, as in we have so many patients enrolled into the trials, but we do not have their quality of life data, or we have the data, but we did not publish it, which is a huge disservice to the patient. So we need to fix this as a society, to be honest. We need to get quality of life information from the patients who have been enrolled into these trials. But when we analyze the data wherever it was available between improving PFS and improving quality of life, the correlation was very weak. So our answer was improving PFS does not correlate with improving quality of life, because you would think that if you delay progression, then quality of life improves. But quality of life is not only the function of disease progression or tumor size, it is also the function of the drug toxicities. So on balance, quality of life can even worsen. And that is what we found in this study, where we looked at PFS, OS, and quality of life of 45 randomized trials. And we found several occasions where the drug improved PFS, but quality of life actually worsened. But reassuringly, we did not find any such instance for drugs that improved overall survival. So as in future video lectures, we'll discuss about how these individual surrogate endpoints are defined, and why improving PFS may not correlate with improving OS and improving quality of life. But for now, I'd like to leave you with an interesting thought that we have been talking about overall survival as clinical endpoint and others as surrogate endpoints. But sometimes even overall survival can be a surrogate endpoint. Now, what do I mean by that? If the overall survival is from a phase 2 clinical trial, then it's not the same as overall survival from a phase 3 clinical trial. So of OS data from phase 2 should also be taken as just a surrogate and not as the real endpoint. I'll give you an example. This is a drug called olaratumab in sarcoma. This drug underwent a phase 2 trial, and in phase 2 trial, it improved OS by 12 months. Now that is unprecedented. We don't see 12 months or 1 year OS difference in oncology very often. So it was a 1 year improvement in survival, which was amazing. But this came from a phase 2 clinical trial. But because it was such an unprecedented survival benefit, several regulators approved this, payers paid for this. But they conducted a phase 3 confirmatory trial, which was the right thing to do. And I actually applaud this trial and the investigators, because we see several accelerated approval where the confirmatory trial is not done in time. In this case, the confirmatory trial was conducted properly, appropriately, timely. And in the confirmatory trial, we saw that there was no OS difference. That means a 12-month, 1 year survival benefit that you saw in phase 2 was a false positive. It just vanished in the phase 3. But we were so excited about 1 year survival advantage that we saw in phase 2 that we all thought that this was going to be a great new drug for our patients. But even 1 year survival benefit, it just disappeared when we did a phase 3. That's why it is so important to look into phase 3 data for making our clinical decisions. You'll see that more and more drugs nowadays are even approved on the basis of responses, response rates, duration of response. And this is particularly true for targeted drugs, or so-called precision oncology drugs. But we did a research in which we compared the response rates and duration of response for these targeted drugs from single-arm trials and compared that with randomized trials. And we found that response rate, but especially duration of response, was highly inflated in single-arm trials. The same drug in the same setting, if we did a randomized trial, you would find a lower duration of response and response rate compared to a single arm trial. That means even response rates, duration of responses in a phase 2 or a single arm trial, we need to think of them as only a surrogate for response rate and duration of response in a phase 3 trial. So that's all for today. In the next video, we'll be discussing about the REGIST criteria and how these surrogate endpoints are being defined. Thank you.